Good evening, friends. It's Facebook time again, and today, as usual, we discuss a very important topic. I mean, it's actually very pertinent today that we discuss topics which not only have some amount of scientific relevance, but also a lot of social relevance. And today we have touched upon one of those topics which have a important social standing in our society. Infertility, is it all her fault? Is the lady to be blamed for everything that is connected to infertility? Upfront, in a very simple and a very pragmatic way, I could say absolutely no. Ladies are not to be blamed for the same. It is a contributory sort of a responsibility for infertility. And in the next 10 to 15 minutes that I'll be with you, I intend to put my point across in as simple words as possible. To begin with, let us talk about what is infertility. Well, the scientific bodies all over the world have defined infertility as failure to conceive despite a complete year of a couple staying together. That is, they stay together, they have regular intercourse, and they don't use any contraceptives. We generally stick to these definitions in a bulk of our cases. But of course, there are a few exceptions when we deviate from this. For example, if the couple is slightly elder in age, or let's say they're crossing the age of 35, that's what elderly actually means in terms of infertility because of obvious reasons. That is, the gamete quality gets affected after that, especially in the ladies, the female partner. Sometimes there are disease conditions wherein we really wish that people conceive faster. Malignancy is just one of them. Also, sometimes we just bend the definition to help the couple tide over social problems. Might be the husband is going out on a foreign trip, or he's working outside, the lady is working outside, there are academic reasons. Whenever there is a social pressure for the lady or the couple to conceive earlier, we would want to slightly bend this definition or this time period of a year or so. Well, I mean, as we coming back to the topic, is it all her problem? As I said, it's obviously no. But what is the contributing factor when it comes to the male and the female? Well, it is very simple. Approximately one third of the infertility in a couple can be attributed to the female. But the next one third is generally attributed to the male partner. Most of us wouldn't know this. The remaining one third is generally mixed. That is, both the male and the female would contribute to the cause of infertility. But however, I mean, of course, this one third, one third, one third is not exactly scientific, but this is for general consumption. But despite the equal contribution of male and female partners towards the etiology or the cause of infertility, the female tends to get blamed for it a lot. Why? Well, I did think about it a lot. Possibly the female is a weaker sex. Well, not according to me, because the female is a stronger sex according to me. Or is it because the society norms, the social norms are such that we tend to blame the female for everything? Possibly so. I really wonder why. But I think the main reason as to why the female gets the brunt of the blame is because she not only helps conceive, but she is the custodian of the pregnancy. The lady carries the baby throughout the 9 months of the intrauterine gestation. So she tends to harbor the bulk of the blame. Or possibly one of the other reasons as to why the female partner tends to bear the heavier part of the cross is possibly the difficulty in investigating a female. It is very difficult to pinpoint the exact reason in a female because there are so many micro steps which lead to the final diagnosis or the final pinpointing of the cause. As far as the male partner is concerned, it is slightly easier. All we generally require is a semen analysis. One shot into the container, and you generally get the answer whether the product is good, the product is not so good, and then we work on from there. In the ladies, it's a huge sort of a step by step approach that we have to take, right from the brain down to the lowest part of the cervix and the vagina. Everything, every level needs to be investigated. When we look back and see the holistic approach in a male and a female, the functions are different. In a male, possibly the entire reproductive system is designed only to produce the gametes. The gametes are produced, and that's the end of the journey. Of course, they do help in copulation, but this copulation part is also played by the female. When it comes to partner, the female partner not only produces the gamete, that is the egg, but it also nurtures these gametes in the initial few days. The female also nurtures the resultant embryo in the first 5 days of life. That is from day 0 to day 5, till actually the embryo implants into the uterus. The living embryo is nurtured. It's being given a stable culture system within the body of the female partner for the embryo. Plus, not only that, the implantation is within the uterus of the female, and the journey begins for the next 9 months within the uterus of the lady. So there are so many functions. Of course, the function of parturition or the delivery is also there. When a person is doing so much functions, when the female partner is doing so many functions, so many varied functions, so many different interplay of hormones, structures, chemicals, physiology, anatomy, everything interspersed, intermixed, braided together, the complexity increases. And more the role, the more is the blame. It is no other reason, even though per se, both the male partner and the female partner contribute approximately 50% of the reasons. Also, one of the greater misconceptions that runs in the society is the fact that every person thinks if the male ejaculates and he has an erection, if these two functions are fulfilled, he is generally potent or his fertility potential is good. But what most of us don't realize is these are main functions for the intercourse part of things, not the fertility. If you divide a semen sample, it has two parts, the solid component and the liquid component. The liquid component actually has no role, or rather, I would say, a very little role as far as fertility is concerned. The fertility essence or the power generally lies in the solid component or the sperms. How much sperms are there is not indicated by the volume of the ejaculate. What the potential, the power of the fertility potential of the semen is entirely dependent on the number of spermatozoa which are present in the semen sample. Also, what is more important is what is the nature of the sperms that have been ejaculated. This, unfortunately, cannot be assessed by anyone until and unless the semen sample is put under a microscope, a specialized microscope, and two specialized eyes look into the semen sample and tell us how good is the semen sample. This misconception needs to be removed from the society. Just mere erection and ejaculation is not equal to fertility potential. This must be percolated down into the society. And the more we educate our children, the more this sort of education goes into the system, into science, as we grow up, I think the brunt of the load of the blame of infertility will be equally harbored by both the male and the female. And when you look at the sperms per se, the end product is a very sort of a complex sort of structure. The spermatozoa is a beautiful structure, defined by God in such a way that everything is compressed, and the head contains the entire genetic material that is required to make an offspring. And this complexity actually increases the probability of having defects. These defects can be in terms of structure, the defects can be in terms of the DNA packaging that goes into it. There might be harmful radiation which the testis is exposed to, and this causes something called as DNA fragmentation. And if this DNA fragmentation index is high, it leads to poor embryo formation, poor implantation. And despite the fact that the female might be absolutely normal, the male count is good, but the couple will not conceive because of this problem of DFI, and it's absolutely not visible at times. It requires a couple of tires of investigation to actually reach the diagnosis of increased DFI. Also, as time goes by, or if the man is inflicted with not so good habits like smoking, alcohol, consumption of drugs, or unfortunately infected by diseases like mumps, or there has been trauma, sometimes all these things add up to a gathering of harmful chemicals in the testis. Now, these chemicals are called as ROS, or reactive oxidative species. The presence of ROS in a titer or in a level which is not good means there is going to be an impact on the fertility potential of the male. Again, this cannot be very easily diagnosed or seen. So there are so many more small things which actually add up to the male infertility part of things. And all said and done, most of it goes undiagnosed. And hence, possibly the blame starts to fall on the female partner. There are certain chemicals which actually help binding to the oocyte. Simple chemical, I'll take a technical name, it's called PLC zeta. If a certain chemical called PLC zeta is just missing from the sperm, that means the fertilization isn't going to take place. It's just a small chemical, but the entire process is just halted at that point of time, and everything else might be normal. But for us as infertility specialists to diagnose the PLC zeta deficiency, it takes a lot of testing, it takes a lot of investigations, and it takes a lot of mind power to actually reach that point in time of that level of diagnosis. Well, thinking of a very holistic view, well, is the blame game really necessary? Well, actually, no. The decision when a couple decides that yes, we are partners and now it is time for us to become parents, that point of that decision making is possibly the most important thing. And this joint decision is what makes life better. This decision to partner each other in times of sorrow, in times of happiness, in times of grief, is what carries life forward. Well, I'll give you an example slightly later about how nature looks after each other. But not deviating too much away from the topic, we as doctors also wouldn't try to compartmentalize the couple into male and female. We generally look upon the male and female partners as a unit, as a couple. And hence, most of our clinics, you would realize that we start investigating both the male partner and the female partner together. Of course, it does save time. You investigate one partner and then you realize, oh God, the other partner has these many defects. Possibly we lost a lot of time before we actually hit that point. So to save time, of course, we start investigating together. But more important is rather we wouldn't want to compartmentalize it is your fault or it is your fault. No, it isn't so. It is the fault of the couple. It is the fault of the unit which is sitting in front of the doctor. And hence, we also try to inculcate this feeling that this journey through infertility has to go hand in hand. The sense of togetherness has to build up as the treatment increases in complexity or increases in time or increases in difficulty. We wish that the bond of togetherness becomes stronger, and hence, when you become a family later, this bond will be even more strengthened by the presence of the child. All said and done, as I said, there is always a possibility that how nature teaches us, both the sperm and the oocyte have a lot of DNA in them. And the beauty is that they have more than required DNA. So, if there is a defect in the sperm, the oocyte gives its spare DNA to repair the damage of the sperm, and vice versa. This is exactly how nature tends to help each other. So, to all the infertile couples all over the world, my message today is very simple: look after your partner. Don't try to find the blame in the partner. Let's try to find out what is the strength in your partner, and that will take us miles ahead in life and possibly an easier way to achieve what we call as family or the ultimate success when it comes to the treatment of infertility. I thank you for a patient hearing, and I guess I will take a bit of questions depending on the questions as it comes upon the screen. Uh, Miss Preeti has asked a very good question as to when should a couple start their investigation for infertility. Preeti, it's a wonderful question. All said and done, the definition of infertility says unprotected intercourse for about a year or so. That is exactly when a couple should start investigating. Of course, if there is an intelligent person, I mean, an intelligent couple sitting in front of me, and most of them are actually, because no one would knock the doors of an infertility clinic without having actually tried. They know in their mind that yes, the time is correct to go and knock the doors of the clinic. We as clinicians would like to supplement this decision of yours. Whenever anyone comes, at least I generally try to get a semen analysis, just see the tubes are patent, and see if the lady is ovulating. If these three things are good, then possibly I would let them off for a little more time. But yes, as a layman, as patients, as general society, when do you start investigating? I think 1 year of unprotected coitus, and I think you should seriously start looking into treatment options, or rather, at least investigating options, because the more you delay your decision to get yourself investigated, you are losing time. And this time you will never get back. And what you'll also not get back along with the time is the quality of your gametes, which will keep on depleting as time goes by. Gautami has asked, what are the tests that are done for the female partner in case of infertility? Gautami, thanks for the question. I mean, there are a huge lot of tests that needs to be done for both males and females, but since you've restricted yourself to a female partner, well, the main thing upfront, if you can actually see, is let's see, is the gamete being produced in adequate quantity? Number one, that is the ovarian reserve good? Is the lady ovulating? There are certain tests that needs to be done for this. It can be done by hormonal assays. It can be done by ultrasound. The second thing is, what is the structure of the uterus? I mean, the structure of the female genital tract. We would like to do an ultrasound. Ultrasound also helps us give an indication of ovarian reserve through something called as antral follicle count. Also, in the structure, what we would like to see is if the tubes are patent or not. Of course, there are other levels of investigation, like some small surgeries called as hysteroscopy, laparoscopy, wherein we try to look into the uterus, look into the peritoneal cavity, that is into the abdomen, to see if there is any adhesions. There is something stuck onto the uterus. There's something which is impeding the flow of semen. There could be many small things which actually contribute to the larger cause of infertility. All these things needs investigation, and if at all everything is fine, then we might actually have to prep up our level into genetic analysis of the female also. Yes, and one of the other things which I forgot is possibly the hormonal assay. But yes, the hormonal assay is again the hormone analysis, that is again a reflection of the ovarian reserve or the fertility potential of the female. So these are the things that we generally look for. Also, what we look for as a generalistic attitude is whether the lady is free from diseases, We look into HIV status, HBsAg, VDRL, etc., etc. Plus, also we look in for, if the lady is suffering from thyroid disorders or diabetes and things like that. So all these things we generally try to look into while we are actually investigating the female partner whenever there's a case of infertility. Uh, Lavanya has asked a very good question, that is, do all cases of infertility actually require IVF? Well, Lavanya, no. We generally don't advise IVF to all the couple. I mean, all the couples who knock our doors. Generally, around one third of them would require. If there is one minor correction that needs to be done, then we could do it with the help of timed intercourse, explaining the correct time to have the intercourse. We could do with something, a minimal stimulation or an ovulation induction and a timed intercourse, an ovulation induction, IUI. There are so many more small things that can enhance the fertility of a couple before you actually hit on to the final nail in the coffin, that is actually IVF. But of course, there is also another huge aspect which needs to be addressed right here. That is, if there are structural anomalies in the uterus, suppose there's a septum, even a mere excision of septum can lead to reversal of infertility issues. They could be just tuboplasty which is required, just cannulation of the tubes, or else there could be some flimsy adhesions which is present in the within the uterus. We just cut them open and the lady conceives. And not so, yeah, not all cases would require IVF per se. But yes, the ultimate weapon that lies in our hands, of course, is IVF. I hope that answers your question, Lavanya. Akila has asked, Akila has touched upon the male partner this time. Akila is asking what are the tests that the male needs to do. Well, Akila, the basic test that we advise for a male partner is, of course, a semen analysis. But as I've also said, we would also like to rule out any infective etiology like HIV, HBsAg, because these diseases can be prevented by certain methodology, and the offspring can be protected from these diseases. Of course, we also look into the semen culture, which needs to be done. If at all there is a problem in the semen analysis per se, then we go into a deeper set of investigations like hormonal assay, possibly trying to get into a needle biopsy of the testes. And there are many, many more, including karyotyping or chromosome analysis. All those things could be done. But the basic test would be an infective profile, ruling out any generalistic medical illnesses, and of course, a semen analysis, which forms the basis of all male partner investigations. I hope that answers your question, Akila. Lavanya has come up with another question, that is, does infertility treatment increase problems in the offspring? Lavanya, I think I'll take this question in a slightly different way. Let's talk about, let's say, obstetric problems per se. I hope I'll answer your question in this way, that is, one is the obstetric problems, and the second happens to be genetic problems. So I'll take it one by one. Obstetric problems, yes, unfortunately, what happens in IVF, post IVF, due to the different procedures that have been done, or because of the drugs that have been exhibited to the lady, there is a slight incidence, increased incidence of obstetric problems. Obstetric problems means things like antepartum hemorrhage, postpartum hemorrhage, gestational diabetes, pregnancy-induced hypertension, or preeclampsia as it is called nowadays, etc., etc. These are obstetric problems, which are minor problems, which we anticipate in all the patients who have undergone IVF, and hence all patients who have undergone IVF, we do consider them as very special, and we generally treat them with a much more higher pixel or a bigger magnifying glass, or we are a little more proactive when it comes to treating an IVF pregnancy. Now let us talk about the second part, which is possibly what I think she hinted at, is genetic problems. Well, upfront, I would plain and simple say absolutely no. Infertility treatments wouldn't increase any increase in the genetic issues that the offspring would have. If you look at the generalized population, the entire world or the entire society, there is a certain level of congenital issues which are prevalent in the society. Now, this is applicable to everyone, whether it is natural conception or it is assisted conception. Now, there are second sort of a society which exists. One is people with normal fertility, then there's a people with subfertility. Now, the mere presence of being subfertile or being present in the subfertile population increases the genetic issues or the genetic chromosomal anomalies which are present in the society. So, if we consider the level of normalcy here, the subfertile population would be here. And any of our procedures, that is IVF or IUI, would generally keep the procedure level at the level of subfertile. So our procedures per se will not increase the congenital malformations or the genetic issues. But yes, there are certain things like prolonged culture at times. There are certain things which at times are not investigated still because our specialty is a relatively young specialty. We're just about a little over 40 years into the subspecialty. Possibly later things might come up. But yes, all said and done, we are all very scientific people, and everything that we adopt slowly is investigated, re-investigated, and re-investigated before we actually let it loose onto the generalized population. I hope that answers your question, Lavanya. And let's see if lovely Sony has asked, are there any side effects of IVF on the female partner? Lovely, I mean, this is actually a lovely question because I have got this question from a lot of my patients. After IVF, people tend to put on weight, there are hormonal disturbances, etc., etc. But I think these are all old granny's tales as of now. The drugs that we have today are recombinant in nature. Some of the urinary products are so very pure, it is absolutely just like what your pituitary secretes. The drugs, the dosages, everything can be got so close to normalcy that the IVF today per se has become a very, very relatively smooth procedure, and the procedure per se is devoid of any major side effects, even for the female partner. Yes, but get it done through a good clinic, get it done through a qualified person. Make sure that the person doesn't overstimulate you, or the overstimulation actually leads to a certain condition called OHSS. That's the only side effect that I would know of, I mean, per se, because the rest of the things can be easily managed. And even OHSS to a large extent, we all today aim to run something called as OHSS free clinic. And as a result, these are scientifically documented methodological steps if we do undertake in our, or which we embrace in our day-to-day clinical practice. I think most 99.9% of the side effects of IVF can be eliminated. Thank you, Lovely, for the question. And let's see if there are any. Gautami asks, how should we choose the place of investigation and treatment? Gautami, I mean, it's a very broad sort of a question that you've asked. Well, IVF requires specialized training. Let's put it up front. So I would suggest that if at all someone really needs to get themselves treated in a methodological manner, then you should knock the doors of a correct clinic. Make sure that the clinician who's there or the embryologist who's there is properly educated, in the sense, look at the degree. It's very easy. Most of the clinics would display what the doctor has done as far as education is concerned and training is concerned. So choose a clinic which has a proper clinician who's got the proper training. Choose a clinic which has a full-time embryologist, and choose a clinic which has been accredited by the ICMR, and that's a medical body. So if you look into these three basic structures, I think that's the area where you should actually go and investigate yourself or get yourself treated. I hope that clears the doubts of yours, Gautami. Raziuddin has come up with a question. As a society, is there any way we could reduce this blaming of the female partner? Wonderful question, Razi. I mean, well, ultimate aim of this talk is to address this question. As a society, we should educate ourselves first, our children, our friends, and the society per se, that both the male and the female contribute to infertility. And this blame is almost equal. I wouldn't call it blame, I would call it the reasoning or the etiology is almost equal on both the male and the female. The aim entirely should be, as a unit, you go to a doctor, get yourself investigated properly, get yourself treated properly, and at the end of the journey, the bond between the male and the female is stronger than when it began, when this journey of infertility began. And if this is achieved, I think we have achieved our goal. I don't think I see any more questions. And oh, there is one from Fatima. What are the tests that are done for the female partner? I think this I've already addressed. I think we just have to divide into three parts. I mean, just see if the lady is ovulating well, the tubes are patent, and the uterus is good. Apart from the other investigations like infectious like HIV, HPCG, etc., and any generalized diseases like thyroid and let's say uh, diabetes, etc. Since I've already answered this question, so I'm not going to too much of detail into this. Within the blink of time, I mean, I didn't realize it's almost half an hour since I started talking, and the topic itself is so engrossing. I mean, and somehow the entire thing about lifting up the society as a part of infertility training also is a subject which is very close to my heart and the institution that I work in, that is Oasis Fertility. We do respect our patients. We do respect our patients for their choices, and that is entirely what we aim to actually give across to the society. Do visit us if at all there's any problem, and let us know if there's any topic that you wish me or one of our team members to elaborate on in the future lectures. Thanks a lot. Thank you for your time and a patient hearing.